Good afternoon, everyone. My name is Kyle Brown. I'm the Bite-Sized Lecture Coordinator for the Southeast chapter of SCCM. Thank you guys for joining us today. I am very happy and honored to have our distinguished guest today present to you a topic on cardiogenic shock management. Before I introduce our speakers, I do want to open up with our mission statement, which is to emulate SCCM's mission, which is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities as well as promoting multi-professional collaboration. As I mentioned, we have a distinguished multi-professional group today to present to you cardiogenic shock management. First, I would like to introduce Dr. Chelsea Moran. She is a graduate from the University of Kentucky College of Pharmacy and completed her pharmacy residency at Piedmont Atlanta Hospital. After her residency, she worked at Piedmont for 6 years between the general cardiology units as well as the cardiac ICU unit. Currently, she works at the University of Kentucky Healthcare in Lexington and works with all inpatient cardiology teams, particularly the general cardiology, cardiac ICU, cardiothoracic surgery, as well as the advanced heart failure team. Next, we have Andrew Goodner, or Drew. He is a physician assistant on the cardiac critical care service at Piedmont Atlanta Hospital as well, and he specialized in the management of advanced heart failure and cardiogenic shock patients, particularly those on mechanical circulatory support. He is passionate about early recognition of cardiogenic shock and time utilization. And next, we have Jackson Bond. He is a registered nurse at Piedmont Atlanta Hospital, primarily in the cardiac ICU. When he's not taking care of severe cardiogenic shock, he is also serving as an assistant director in nursing education for the cardiac unit as well. So I am pleased to have these speakers join us today, and I'm going to let Dr. Moran start us off.
All right, can you all see my screen?
Yes.
Perfect, thanks, Kyle. All right, thank you so much for that intro, Kyle, and thanks for having me today. Again, I'm Chelsea Moran, and I'm a cardiology clinical pharmacist at UK. I did work with Kyle, Drew, and Jackson at Piedmont, and they were an awesome group to work with, so I'm excited to join them here today. Here are the objectives for my portion today, and not surprisingly, the focus of my portion is going to be the pharmacological management of cardiogenic shock. When we think about cardiogenic shock, there's not one clear specific definition, as it's a pretty heterogeneous disease state. In March of this year, the American College of Cardiology published a consensus statement in the AACC to provide concise guidance for interdisciplinary teams involved in evaluating and treating patients with cardiogenic shock, and they define it as a cardiac disorder that results in both clinical and biochemical evidence of sustained tissue hypoperfusion irrespective of underlying blood pressure. There's a variety of causes of cardiogenic shock, and some examples include an acute MI, acute decompensation of heart failure, RV failure, severe valvular heart disease, arrhythmias, or pulmonary embolism. It's super important to make sure we treat the underlying cause of cardiogenic shock as well. The AACC gives us a mnemonic to help confirm the diagnosis of cardiogenic shock called SUSPECT-CS. This includes the signs and symptoms, such as AMS, chest pain, cold extremities, and surrogate markers of volume status, oliguria or anuria, sustained hypotension, markers of malperfusion, such as end organ dysfunction or elevated lactate, an EKG that shows a STEMI or an echo that shows RV, LV, or valvular dysfunction, congestion, and then finally triage to either activate the shock team or transfer to a higher level of care, which Drew's going to talk to us a lot more about. We also have our SKY stages of cardiogenic shock. The goal of this classification system is to clearly display shock severity. Once a diagnosis of cardiogenic shock is made, it should then be classified using the SKY stages. Studies have validated the correlation of shock stage to mortality, and hence the progression between each stage is usually a gradient, which you can see in this image. This overview shows how the SKY stage of cardiogenic shock relates to a patient's physical exam, biochemical markers, and hemodynamics, which is the handy graphic from our ACC consensus statement. I'm not going to go over each of these individually, but I'm going to use Sky Stage C as an example, since when we talk about the Do-Re-Mi trial, the majority of patients in that trial were Sky Stage C. Patients in this stage require intervention, either pharmacological or mechanical, to help with their hypoperfusion. Physical exam includes elevated JVP, altered mental status, extensive burials, and urine output less than 30 mils per hour. Biochemical markers are an elevated lactate and evidence of end organ dysfunction, as well as an elevated BNP. Finally, hemodynamic markers, including systolic blood pressure less than 90, or MAP less than 60, or a 30-point drop from baseline, or a cardiac index of less than 2.2, and a wedge greater than 15. And since I'm talking about cardiac index and wedge pressure, here's a really quick review on our hemodynamics. A pulmonary artery catheter, also called a Swan-Ganz catheter, is inserted usually into the right IJ and advanced into the right atrium. The right atrial pressure is roughly equivalent to the CVP, or central venous pressure, and is a surrogate marker for preload. A CVP of greater than 12 suggests congestion and that diuretics may be beneficial. It then goes into the right ventricle. The RV pressure is a surrogate for pulmonary artery systolic pressure. Next, it goes into the pulmonary artery where it remains, and the pulmonary capillary wedge pressure is a surrogate for left atrial pressure and LV-EDP. This helps us estimate fluid status. Now, when we look at the table on the right, the cardiac output is heart rate in beats per minute multiplied by stroke volume, which is the amount of blood pumped out of the ventricles with each contraction. We typically use cardiac index instead of cardiac output because the cardiac index is our cardiac output standardized to BSA. This is our surrogate marker for perfusion. And then finally, systemic vascular resistance is an estimate for afterload. Our patients can be classified into different Forrester hemodynamic subsets that are based on their cardiac index and their pulmonary capillary wedge pressure. Cardiac index, which we have on our y-axis, indicates the degree of perfusion, and patients are classified as either warm if the cardiac index is greater than or equal to 2.2, or cold if it's less than 2.2, which indicates hypoperfusion. Pulmonary capillary wedge pressure indicates volume status. Patients are either wet if their wedge is greater than or equal to 18, or dry if it's less than 18. Our cardiogenic shock patients will fall into class 4, which is considered cold and wet. They're volume overloaded and they're not perfusing well. Mortality in the subset is quite high at 51%. For patients with cardiogenic shock, the main goals are straightforward: to alleviate congestion, optimize cardiac output with the end goal of enhancing organ perfusion. To alleviate congestion, we'll usually use diuretics or renal replacement therapy, and to optimize cardiac output and enhance organ perfusion, we use IV vasoactive medications and afterload reduction. For our patients who present with volume overload, diuretics are going to be our cornerstone treatment. Congestion can lead to microcirculatory ischemia and multiple organ damage, including the kidneys, liver, and GI tract. Congestion is usually treated with IV loop diuretics, thiazide diuretics for sequential nephron blockade if IV loop diuretics alone are insufficient, or renal replacement therapy. Our IV loop diuretic workhorses are going to be furosemide and bumetanide. Oral bioavailability of furosemide is variable, but the consensus is that the IV to PO conversion is 1 to 2. When patients present with congestion, a common question is what dose of diuretic should they start on, and is it more beneficial to use IV push doses Q12 hours versus a continuous infusion of a loop diuretic? The dose trial helps us answer that question. Patients were stratified to receive either a low-dose strategy where the total IV furosemide dose was equal to the total oral daily dose, or a high-dose strategy where patients' total IV furosemide dose was equal to 2.5 times the total daily dose of loop diuretic. So remember what I just mentioned, if we take into account of the IV to PO conversion of loop diuretics, the transition would actually be considered a doubling of the home diuretic dose in the low-dose group, and for the high-dose groups, this would be a 4 to 5-fold increase in the home dose. Patients were also stratified into an IV bolus or a continuous infusion group. At 48 hours, the diuretic dose could be increased by 50%, kept the same, or the IV treatment could be discontinued and changed to PO. At 72 hours, all treatment was open label, and patients were followed for clinical events up to 60 days. Here we've got our inclusion and exclusion criteria as well as baseline characteristics. Of note, patients were excluded if they had a systolic blood pressure of less than 90, their serum creatinine was greater than 3, or if they required IV vasodilators or inotropic for heart failure. So these patients wouldn't necessarily fit our cardiogenic shock picture, but they would be at risk of decompensation. The primary efficacy endpoint was the patient's global assessment of symptoms, measured using a visual analog scale and quantified as an AUC of serial assessment from baseline to 72 hours. The primary safety endpoint was change in serum creatinine from baseline to 72 hours. For the primary efficacy outcome, we've got our global VAS score on the y-axis and hours on IV furosemide on our y-axis, and then the oral dose or the IV dose of furosemide on the x-axis. A higher VAS score corresponded to patients feeling better. There was no significant difference in patient-reported global VAS for the bolus versus continuous infusion strategy as seen on the left, or the low versus high dose strategy as seen on the right, but you can see a little bit of separation in the AUC of patients in the high dose group reporting feeling better on the right side. There was also no statistically significant difference in change in serum creatinine with the bolus versus continuous infusion strategy or the low versus high dose at 72 hours. There was no difference in dyspnea, weight change, net fluid loss, or change in creatinine at 72 hours between the bolus or the continuous infusion group. However, more patients in the high dose group were able to change to PO diuretics at 48 hours, did not require a dose increase at 48 hours, reported less dyspnea at 72 hours, and had a greater decrease in weight and more net fluid loss at 72 hours. There was a statistically significant difference in increase in serum creatinine of greater than 0.3 mg per deciliter within 72 hours with the high dose group versus the low dose group. But recall, as part of the primary outcome, there was no significant mean change in serum creatinine over 72 hours. Overall, there was no significant difference between the bolus versus continuous infusion diuretic groups in relation to symptom control or change in serum creatinine. High-dose furosemide resulted in greater net fluid loss, weight loss, and relief of dyspnea. High-dose furosemide did lead to some worsening of renal function, but this did not lead to worsening clinical outcomes at 60 days. A big takeaway from this trial is that patients may be able to actually receive higher doses of loop diuretics without adverse effects, since patients in the high-dose group received 4 to 5 times their oral furosemide dose equivalent when we convert it to IV dose based on the bioavailability of that furosemide. As a nice review, the AACC consensus statement includes this chart outlining our different vasoactive medications. There's not super clear recommendations on when to use one agent over another in cardiogenic shock, but our workhorses are typically our ionopressors, ionodilators, and vasodilators. Our ionopressors are norepinephrine, epinephrine, and dopamine. They increase cardiac output, but they also increase SVR. Our ionodilators are dobutamine and milrinone. They increase cardiac output and reduce afterload through systemic vasodilation. Our pure vasopressors are phenylephrine and vasopressin. They increase MAP by increasing SVR. We typically do not use these agents for cardiogenic shock. Pure vasopressors can cause reflex bradycardia and reduce cardiac output in cardiogenic shock, so they're not good first-line options. And last, our vasodilators, nitroprusside and nitroglycerin, decrease preload and or LV afterload through reducing SVR, which can help augment our cardiac output. First, we'll take a pretty brief look at our ionopressors. The Optimus UC trial randomized 57 patients with acute myocardial infarction cardiogenic shock to receive either epinephrine or norepinephrine. Researchers found that both drugs increased MAP and cardiac index, but patients who received epinephrine showed higher rates of refractory shock, as seen in the bar graph on the right, so the study was terminated early. Patients who received epinephrine also had high rates of lactic acidosis, marked and sustained increases in heart rate, and increased cardiac double product, which is a marker of myocardial oxygen consumption. There was no significant difference in mortality at 60 days between the two groups. And I know that y'all are familiar with the SCOPE-2 trial. This trial showed no significant difference in the rate of death at 28 days in patients with shock who received norepinephrine or dopamine, but there were more serious adverse events in the patients who received dopamine, including arrhythmias. A subgroup analysis of this trial showed that dopamine was associated with an increased rate of death at 28 days among patients with cardiogenic shock. There is no clear consensus, but norepinephrine is a reasonable first-line vasopressor choice for patients with cardiogenic shock who are hypotensive per the AACC expert consensus statement. And now onto our ionodilators, milrinone and dobutamine. Milrinone is a PDE3 inhibitor that increases cardiac ionotropy, lusitropy, and peripheral vasodilation. Dobutamine is a beta-1 and beta-2 receptor agonist that increases blood pressure by increasing cardiac output. Of note, milrinone is renally cleared and often associated with causing hypotension, which is more common in patients with renal dysfunction. Milrinone has a longer half-life of around 2 hours compared to the very short half-life of 2 minutes for dobutamine, and both agents are associated with arrhythmias, but observational studies have shown that dobutamine may be more arrhythmogenic than milrinone. Our ionodilators were compared to each other in the DORE-ME trial, which was a single-center randomized double-blind trial. Patients with cardiogenic shock were assigned 1-to-1 to receive either milrinone or dobutamine. We have our inclusion and exclusion criteria listed here, as well as our baseline characteristics. And I want to point out that 80% of patients in this study had Sky Stage C cardiogenic shock, which is that group that we reviewed earlier. The primary outcome was a composite of in-hospital death from any cause, resuscitated cardiac arrest, receipt of cardiac transplant or MCS, non-fatal MI, TIA or stroke, or initiation of renal replacement therapy. There was no statistically significant difference between the two groups regarding the primary outcome or in any individual component of the primary outcome. There was also no difference in cardiac ICU length of stay, total duration of inotropic treatment, need for renal replacement therapy, AKI, normalization of lactate level, or arrhythmia leading to medical team intervention between the two groups. Overall, there was no significant advantage of milrinone over dobutamine found in this trial, and there was also no difference in arrhythmia occurrence between the two groups. Lastly, we'll talk about our vasodilators. Outside of the CCU, there may be some hesitance to use afterload-reducing agents in patients who are hospitalized with cardiogenic shock. It does seem counterintuitive to use an agent that decreases blood pressure in a patient who has low cardiac output or an already marginal blood pressure. However, the improvement in cardiac output offsets the decrease in blood pressure typically. Reduction in afterload with these agents usually leads to a marked increase in cardiac output and prevents the development of significant hypotension. Nitroglycerin is not renally eliminated, and one of its main adverse drug reactions is tachyphylaxis after 24 to 48 hours. Nitroprusside is renally eliminated, and its thiocyanate metabolite half-life is about 3 days, so that can be doubled or tripled in significant renal failure. There's also a risk of cyanide toxicity with this agent. Mullins and colleagues evaluated the safety and efficacy of nitroprusside as part of a treatment regimen for patients hospitalized with acute decompensated heart failure with low output states in a single-center retrospective case-control study done in 2008. The addition of sodium nitroprusside was at the discretion of the treating physician, and there was no randomization in the study. Patients continued on nitroprusside for 24 to 72 hours and were titrated off using the dosing protocol that we have on the right side of this slide when their MAP goals were achieved and optimal hemodynamic measures were maintained. We have our baseline characteristics, inclusion and exclusion criteria listed here. Of note, patients with a cardiac index of less than 2, a wedge greater than 18, or a RA pressure greater than 8 measured via right heart cath were included in this study, so they did fit into our Forrester hemodynamic class 4, and patients were excluded if their MAP was less than 60 at the time of initial right heart cath. If we look at our baseline hemodynamic parameters on the right side, patients who were treated with nitroprusside did have higher baseline filling pressures, higher systemic and pulmonary vascular resistance, a slightly higher blood pressure, and lower cardiac index compared to patients who did not receive sodium nitroprusside. The primary endpoints in the study were all-cause mortality, cardiac transplant, and first readmission for heart failure following discharge. Patients were followed for a median of 26 months after initial right heart cath, and no patients were lost to follow-up. Sodium nitroprusside was associated with lower all-cause mortality compared to patients who were not treated with nitroprusside, and as you can see, the mortality on the curve on the right separates very early and stays separated continuously. The number needed to treat for all-cause mortality is 7, which is pretty amazing, and there was no difference in cardiac transplant or heart failure hospitalization. Also of note, there were no signs of cyanide toxicity in patients who received nitroprusside. The authors concluded that nitroprusside can safely be given to patients with advanced low-output heart failure, and that nitroprusside is associated with improved long-term outcomes. So to summarize everything that we talked about, high-dose loop diuretics lead to improved decongestion with transient worsening of renal function, but not worsening clinical outcomes compared to low-dose loop diuretics. There's no clear recommendations for our first-line inopressor, but norepinephrine is a reasonable choice. There's no clear recommendations on dobutamine versus milrinone because there was no difference between those two groups in the DOREMI study. And sodium nitroprusside can be safely given to patients with cardiogenic shock and low output states. That concludes my portion. Thank you so much for your time today, and my email is here, so please feel free to reach out anytime with any questions. Thanks so much.
Okay, can everybody hear me? Let's see if we can get this going here. Sorry, y'all. Just getting this screen sorted out. So I'm going to pick up where Chelsea left off. I'm going to touch base on a couple of these things, but conceptually, looking at the features of mechanical circulatory support as it works into the management of cardiogenic shock. So understanding its utilization and when to utilize it is the key that I'm trying to get through. And we have to recognize that cardiogenic shock is divided up into several subgroups, but the primary two groups that most people will see are the cardiogenic shock due to acute MI, which is the acute loss of cardiac output and subsequent result in systemic wide hypoperfusion. And then the heart failure associated cardiogenic shock, a lot more neurohormonally adapted and also often presents in a more insidious type of way with a little bit more altered mental status, more subtle exam findings. So a lot of cardiogenic shock can't be pointed to as a single finding in blood pressure or one of the other things, and it needs to be understood as a spectrum. And as Chelsea touched on earlier, that spectrum is a reflection of the mortality that is associated with the different severities of shock. So Sky A, B, C, D, E, all categorically are a steady incline in mortality related to a shock diagnosis. And it's important to recognize that shock is in fact a systemic-wide cellular insult that is depriving cells throughout the system with the oxygen and necessary blood transportation functions that they need to stay alive even at a basal metabolic rate. So thinking about that, touching on the Do-Re-Mi trial, we look at the similarities between outcomes. Mind you, this is a very small trial, but this includes the acute MI and the heart failure cohorts, and we don't really see a big distinction between the outcomes in this. Moreover, these outcomes are very much a reflection of the outcome trend over the last 20 years and does not demonstrate an improvement overall in getting survival and achieving, a patient who can be discharged home or sent for a durable heart replacement strategy such as transplant or LVAD. And we get into the differences or distinctions between norepinephrine and dopamine. It's very minimal. There is some significant improvement in outcomes when you look at epinephrine and norepinephrine, but overall, we're still seeing a survival trend that is not demonstrating an approval and barely getting by on the status quo. However, we live in an era now where there is evidence for a way to improve that survival, and that will get to the point of mechanical circulatory support. But often the case is people don't know when it is time to advance towards mechanical circulatory support. If you look at this right here, this utilizes a hemodynamic metric called a cardiac power output, which I will leave out of the conversation for the moment, but this is a surrogate marker for mortality in patients who are currently undersupported in this state of cardiogenic shock. And you can see that the inflection curve of the CPO kind of begins at around the 0.6, 0.7, 0.8 mark. However, this is significantly changed with the addition of a single vasopressor. You see a big spike in mortality, and adding just a second vasoactive agent can increase mortality even more so, even if you are outside of the point of the curve that we consider to be an improvement in a patient's outcome. So going through the literature, you can see kind of redundant data that is being presented demonstrating that patients who are on significant amounts of vasoactive support, inotropic support prior to the initiation of mechanical circulatory support demonstrably have worse outcomes. And I think the argument can be frequently made, well, of course, these patients are much more sick. Well, the argument I would make as a counter argument is that these patients are more sick because their shock was not recognized early in its stage. They were not initiated on appropriate therapies at the onset of their shock, and they, far before they reach these points, should be considered for mechanical circulatory support if that is an option. So mechanical circulatory support writ large is sort of divided up into right heart support, left heart support, or biventricular support. There are many different devices. Many of them have different indications. So an Impella RP or RP Flex would be something for right heart support. A VA ECMO is going to support both ventricles, but also provide a significant amount of afterload on a ailing heart. So this is a strategy that should be considered with something to vent the left ventricle when people are pushing against a circuit that is draining blood from a left femoral vein, returning blood via a left or right femoral artery, and dumping 4+ liters of blood into an aorta. While that might provide circulatory support, it certainly can be something that works against an ailing heart. Intra-aortic balloon pump is utilized more frequently in the cardiogenic shock with acute heart failure. Related to acute heart failure, there is some evidence to suggest that this does not provide any benefit in cardiogenic shock related to acute MI. And then the Impella CP and 5.5 are the only two active models, and I'll skip over the tandem hearts for now, but the Impella is a left-sided only support device that can be indicated for use in acute MI cardiogenic shock, or in the case of the 5.5 in cardiogenic shock that is going to need more sustained support. Without waxing on and on about the different devices themselves, just looking at the impact mechanical circulatory support has on survival when viewed through the lens of vasoactive agents. There is a distinction between the heart failure cardiogenic shock and the acute MI cardiogenic shock groups. But as we, again, use these sky stages to recognize the severity of their illness, and we look at the number of drugs related to their outcomes, as drug use escalates, plus or minus a mechanical circulatory support device, we see that the more vasoactive agents that are used or required to maintain that person's support, the more poorly their likelihood of survival becomes. And I think what this highlights is whether or not appropriate or aggressive enough mechanical circulatory support is being used early on. And I think the number of vasoactive agents required to maintain a patient's perfusion status should be a great indicator of whether or not a person is being adequately supported on that particular device. Again, time becomes a big part of the equation. So how do we get patients on? How do I know when to do it? Well, looking at the time to escalation in a patient, looking at things like lactate clearance, minimization of vasoactive agents, and the time that they are diagnosed with shock to the time a decision is made about putting them on mechanical circulatory support, we have about a shift worth of time to make that decision to really see a distinction in outcomes. And this is a very, very stark curve separation here at 30 days between those who survived and those who did not when looking at escalation to mechanical circulatory support. And the indicators, again, being vasoactive agents, the number of vasoactive agents, lactate clearance, and I'll touch on that in a moment. We see another study that sort of echoes the findings of the other one when you look at even just a few hours of the difference between escalation to mechanical circulatory support versus a delayed strategy. So when dealing with shock, immediately upon recognition of shock, there should be an immediate assessment for a patient's candidacy for mechanical circulatory support and some clear definitions of what will define their need for that mechanical circulatory support based on biventricular function. More recently, randomized controlled trial was published called the Danger Shock trial that looked at survival using mechanical circulatory support in the context of cardiogenic shock due to acute MI. And there was a very clear distinction in survival between these groups out at 180 days, which I think is a great time horizon to look at. With a number needed to treat of 8, we see an absolute risk reduction of 12.7% in mortality. So these are things that are implemented at the onset of recognition of shock. This is something that was done either in the cath lab at time of arrival for acute MI, or 32 of the patients that were studied in these groups were sent back within 4 hours of leaving the cath lab, coming to the cardiac ICU, shock being recognized, sent back to the cath lab. So almost a fifth of the patients in this study actually did not receive mechanical circulatory support immediately upon primary PCI, but then shortly after. Lactate being a great surrogate marker for how severe patients' illness is at time of presentation. If you look at survival trends amongst these patient groups based on their presenting lactate level, I apologize, I have a code that is not in my unit. Sorry, everyone. So looking at a serum lactate of greater than 5 or less than 5 had a large separation of survival over time. So we can simplify these ideas about what it is that we need to see in order to justify some urgency behind mechanical circulatory support. By using mechanical circulatory support, we mitigate the cellular effects of the medications that we're using. We alleviate the workload of the heart and the metabolic demands placed on the heart to continue pushing along. And often those inotropes are increasing those metabolic demands, often in a time with a patient who has acute MI, induced cardiogenic shock. You're pushing a heart who's acutely deprived of oxygen and becomes dysfunctional to now start working harder, and this can provoke arrhythmias and all sorts of other problems. So using an example of an algorithm by which to recognize the need for a patient who needs mechanical circulatory support, incorporating some concepts of CPO, PAPI, these are things that I want to leave on the table for right now, but the lactate clearance, their initial severity of illness based on invasive hemodynamics. And when those are not available, which they often are not, the total vasoactive burden a patient is experiencing. If you have a patient who's requiring 2 medications to maintain a normal blood pressure or some semblance of perfusion, and their lactate is very high at time of arrival, this is a patient who should be immediately stratified for mechanical circulatory support. And when you see organizations that have done so, and they have done so incorporating these 2 hemodynamic metrics utilized using right heart catheterization or Swan-Ganz catheters, and lactate at time of presentation, you see a really, really stark separation in survival. So the big takeaway from this talk for me is to kind of get everyone on board with where drugs can take you, but also where they cannot. And when you have initiated treatment using a pharmacologic strategy for cardiogenic shock, how soon should mechanical circulatory support factor into the equation, and what are the thresholds to move from pharmacologic therapies to mechanical circulatory support? And the argument in favor of that is that there is a clear survival benefit in doing so. In doing so, we also must recognize that mechanical circulatory support comes with a very large bag of its own troubles. It is not a benign therapy to present a patient with. So looking at all of the possible complications associated with mechanical circulatory support should be both a pre, during, and after they have been initiated with that support, a continuous monitoring of all of the possible outcome complications that can follow along with that. And I'm going to leave it at that. If anybody would like further clarification, more data, or more information, please feel free to reach out.
Or can everyone hear me now? Okay. So I'm just going to be again, I'm Jackson. I've been in the cardiac ICU for a little bit over 2 years now. I'm one of the educators on the floor, but pretty much I'm just going to go through nursing management of all of these different mechanical circulatory support devices that we've talked about. Some things may be repetitive, so I'm sorry, just bear with me. But pretty much these are going to be the main devices that we're seeing at Piedmont, right? So we have our Impella, RP Flex 5.5 or CP, and then balloon pump, ECMO, VA, VV, and then an LVAD too. Again, that's kind of more of a bridge or just an advanced surgical option, but I just wanted to touch on it just because we see a lot of that on our floor. So yeah, so we'll start with the balloon pump. So this is going to be the most common type of MCS that we see on the floor. It's going to be giving the least amount of support out of all of them, just because it's more indirect than direct when you're looking at an Impella or ECMO. So pretty much the indications that we see the most in our patient population, and kind of what we discussed earlier, is going to be cardiogenic shock, STEMI, or just advanced heart failure, and then also for these high-risk PCI procedures too, with these patients with like profound CAD, they'll be also getting balloon pump just for that extra support during these procedures. So what are we paying attention to as the nurse for the most part? So of course, we're doing site assessments on these patients on an hourly basis. That also goes into our charting too. So some of the big things that we're looking at, which they kind of intertwine throughout this presentation, you guys will hear me say it multiple times, but one of them is of course going to be looking for continuous bleeding, right? Is there a hematoma? Is it growing or is it stagnant? Some things we like to do is just outline it with a Sharpie just to kind of see if it is growing. For patients that are having this continuous bleeding too, sometimes the provider will do like an epilyto injection to try to just decrease, like vasoconstrict and decrease that bleeding. And we're also checking sutures too. Something big with this too is if the patient's consistently bleeding and we're having to change these dressings, not only are they losing blood, but it's also posing a huge risk for infection, right? So all of our central line dressing change, of course, are sterile. So just opening this up a lot can just pose that infection risk. So we're also checking the helium tanks on the actual device. It gives you kind of a parameter as to like the life of the helium tank, and we are responsible as the nurse to be changing that. So another thing too is we do tubing changes on all of our drips, and if any type of mechanical circulatory support has like purge fluid for an Impella or heparinized saline for your ECMO or your balloon pump, we're changing those too. Just making sure that our pressure bag is fully inflated and we're not having reflux of blood through that tubing, so we're not clotting off that line. It's really important, and we try to do it every 4 hours. I think honestly it should be just anytime you go into the room, you should just try to flush these lines to prevent any clots, just because if this line is not patent where this heparinized saline is going through, it can cause clots, and then it can also throw off your values on your balloon pump, right? So whether it's fiber optic or transduced, if that line clots off, it can throw off all your readings. So just something important to look at too. Also the helium tubing that's connecting from the device to the patient. Of course, we're gonna look for if there's any type of freckled blood in there or just blood in general, just because that's indicative probably of a balloon rupture and would warrant immediate removal or exchange. So just kind of some important things that we're looking at. Of course, for these patients, because I've only seen maybe one subclavian placed balloon pump. It's very rare, but for the most part, they're placed femorally. And so these patients are limited to 30 degrees. So just to prevent kinking and stuff like that, if the patient were to bend at the waist. So that's something to pay attention to. I'll kind of talk about the VitalGo beds that we use for physical therapy. They're great, and physical therapy, it works very well with them. So one other thing I was going to talk about too was in a code situation, if the patient were found to be in VT with a pulse, there's different triggers on this device, right? So you can trigger off pressure or off the patient's rhythm. So if they were to be in VT, you would want to switch it to pressure if they still have a pressure, and watch that arterial waveform, just because most likely, depending on the rate of the VT, the device would not be able to keep up with it, so it wouldn't be accurate. And then of course, if the patient were to be like coding fully, no pressure, lethal rhythm, most likely I've usually put the balloon pump in standby, just because if it were to inflate on systole, then that wouldn't be beneficial for the patient, right? So you can switch it to an auto mode too, where it'll trigger like in increments, but usually we'll just put it in standby, or at least in my experience, that's what we've been doing. So I put this little chart up here too. All the nurses in the ICU, whether it's CV ICU, cardiac ICU, anywhere with a balloon pump, we're trained for this. So we look at the waveforms, and these were kind of, I don't know if this is displaying on the screen, but that top left one is going to be the optimal timing. So that's going to be what the waveform looks like, or should look like. And then these are going to be the varying waveforms on early inflation, late inflation, early deflation, late deflation. So just kind of something important that the nurses should be also assessing with patients with a balloon pump. So let's go to the next one. So the next device we're going to be talking about, again, there's going to be things that I'll definitely repeat. So for an Impella, similar reasons for the indications, but usually they just need a higher support, or it just kind of depends on which type of Impella you're choosing, right? So kind of what Drew was talking about earlier, you have the CP, which you have flows up to 4, I think, I'm pretty sure on that. And then 5.5 flows up to 5.5. And then for your RP flex, that's going to be the right-sided dysfunction or right-sided like heart support. What we're paying attention to as the nurse the most on the monitor, so on the monitor or on the actual device, the screen is going to display your placement signals, motor current flow, purge pressure, your P level, which is the amount of support that the patient's getting, and then the power source, of course. So mainly the two things I would say that we're focusing on, of course, it's a whole. So we're focusing on all aspects, but for the most part, I feel like we're really paying attention to placement signal and flow, right? As one of the nurses on the floor, we should be able to recognize if your placement signal is becoming too ventricularized, or if it's kind of flattened or like dampened. If it's more ventricularized, the Impella could have migrated further into the left ventricle, or vice versa. If it's flattened, it could have progressed further into the aorta. So hopefully none of these would affect your flows, but we don't want that to happen, right? So this would warrant an bedside echocardiogram to check placement. We also, and I will talk about this too, there's markings on the Impella like line to see where where the Impella is inside of the patient's body. So of course you'd want to check that, see if there was any movement. But then the provider would change the positioning of the Impella if needed based on those echocardiogram results. So let's see. Ideally, some of these can't be subclavian placed. For 5.5, I feel like we see this more with patients that, again, need higher support, but also might be in the ICU for a little bit. We're a pre-surgical ICU, so we have a lot of patients that wait for hearts or some type of surgical intervention. So from a physical therapy standpoint, of course, we want to place this subclavian if possible. And it just allows the patient for more mobility. The CP are usually placed femoral and limit movement as a balloon pump would, and then RP can be placed femorally or in the IJ. So, but something else that we're kind of focusing on, responsible for checking that type of purge fluid, most likely we're using the bicarb just to prevent resting of the motor, of the Impella motor inside the left ventricle. And then again, how I said earlier, we're going to be checking that length at which the Impella has been inserted at. And it should be anchored onto the patient at 2 different places. And then we're doing dressing changes on those patients every 48 hours. What's kind of special about these is the way the cannula goes into the patient's body. It should be at a 45-degree angle. So the Impella reps, I think, are really good about coming on the unit, and the APPs showing us if we're not doing it correctly, just because that can impede with your flows. So usually we just put like gauze under to get that 45-degree angle for that Impella. Again, kind of how I talked about earlier for a code situation, for an Impella, what we do per protocol is we'll drop the P level to 2. So we'll drop it to the lowest amount of support pretty much that you can give, and then we would begin compressions after that. Some patients do lose pulsatility while they have this Impella in, but as long as they have accurate blood pressure and stuff like that, usually you're losing more pulsatility with like an ECMO or something like that, but it can happen on the Impella too if they're getting adequate flow. So if you were to lose pulsatility, you would, of course, make sure that you're getting adequate flow on the device, and then make sure your patient has an adequate blood pressure too. But it can vary on discretion too. For suction alarms, this was something that commonly happens too. Of course, an Impella, just like an ECMO circuit, they're preload dependent. So we're going to watch that patient's CVP. If it was low or the patient were to be dry, we would try to give some type of resuscitative fluid, whether it's albumin, normal saline, whatever it may be. Try to rectify the suction, and then say the patient's at a P level of 7 and they're getting suction alarms consistently, we might drop that level to 6 or 5 to break the suction, is what we always say. And then if we're able to progress it back up, if the patient tolerates it, then we'll bring it back up to the normal setting, or there might have to be some other type of intervention. But that's usually what we do for that. So for ECMO, again, site and patient assessment is going to be really important for these patients just because they're very involved usually. This is just therapy, as we all know, therapy for life-threatening pulmonary or cardiac failure, or both, when no other intervention has been successful or possibly will be. And again, how Drew was talking about, it kind of depends on the patient, and maybe earlier intervention might be better for these patients. So just kind of depends. But again, looking at the site, excessive bleeding, a lot of times this happens more with our VA ECMO patients just because they're cannulated in the same side. For VV, they're cannulated bilaterally. And then, of course, you want to watch any type of hematoma forming, God forbid, but sometimes they can decannulate from the vessel, causing like a rapidly forming hematoma in their groin area or femoral area, which is not ideal, of course, but it's just important that we're assessing this on an hourly basis and charting on that too. Good thing is we do dressing changes every 24 hours. Sometimes it kind of depends on the type of dressing the patient has. Usually we're using that CHG impregnated just to prevent infection and stuff like that. But when you're changing the dressing, it's important to be looking at those sutures, making sure they're all intact on each cannula. Huge thing for these patients, of course, are going to be pulses, right? For our VA ECMO patients, usually almost all of them have an SFA, so they're still getting perfusion to that lower extremity. But again, something super important is you need to monitor pulses, if not every hour, then more. It just kind of depends on how the patient is presenting and if they need further assessment. Again, 24-hour dressing changes, and then we're doing 2 Foley anchors on each cannula just for like cannula adherence to the patient's limb, right? We're going to be monitoring for north-south or Harlequin syndrome, making sure we're checking all the lines for clotting or air embolisms, and again, checking our oxygenator on these ECMO circuits. A lot of the clots will accumulate on the oxygenator, so it's important to just really be keen on assessing that oxygenator, because maybe the perfusionist might have to come change that too. So again, something that's kind of different with these, although they are femorally cannulated for the most part, the head of the bed can be elevated to as much as the patient tolerates with their flows, right? So these cannulas, unlike like a balloon pump, they're a lot more bendable, right? So these patients can actually sit up, and we'll get to physical therapy too, because that's a huge part of this, my presentation. So of course, when we're training the patients, we're log rolling, keeping the hips together, not turning that. And then for our transseptal patients or with an LA vent, we're only going to be turning them to the right, just to decrease that risk of decannulation from the left atrium. For charting and just checking too on an hourly basis, we're checking that sweep FiO2 flows of all the cannulas, whether it's their SFA, their LA vent, their main flow, their temperature, neurovascular assessments. Again, like in Impella, ECMO is preload dependent, so we always have CVP monitoring on these patients, and decreased preload would probably just is not good. So we're really just paying attention to that. For that kind of, going off of that, if they are low on their CVP, usually we can see chugging or chattering is what it's called. We usually have their cannulas dangled off like the feet portion of the bed, and they're suspended in the air, so we can actually see adequately if it might be like chugging or chattering of the lines. One thing I wanted to touch on was physical therapy, of course, is extremely important for all patient populations, but I feel like we have a great, Drew can probably attest, and anybody else, that our PT team is just great at just really assessing the patient, whether it's site or just hemodynamically. I think they're really good at what they do. Going back to what I was talking about earlier, we utilize those VitalGo beds. You can bring the patient actually up to a 180-degree angle without them bending at the waist, which is good, and it helps them being able to ambulate, right? So one other thing I wanted to touch on too is just a code situation or stop protocol. Hopefully this doesn't happen often, but sometimes it does. So I think we have a good system. We have like papers printed out on each ECMO tower within our hospital, and it just gives you the entire protocol. So we usually have one person reading that off, and that's really their only responsibility. Pretty much what that entails is just initiating an epi-drip if there's not already one started on the patients, giving albumin or resuscitated fluids, and then 10,000 units of heparin, and then kind of just basing other interventions off how the patient is presenting, right? Air embolism can warrant a stop protocol. Clots can warrant a stop protocol. Power loss to the circuit can also, which that would be hand cranking the ECMO circuit. So sometimes the motorhead on the ECMO circuit is magnetically suspended. Sometimes it can decouple, which is a terrible noise. And what we'll have to do is we drop our flows, and then we would try to detach the motorhead and then reattach it to see if we can recouple it. But again, if you weren't able to, that would be you hand cranking the circuit. One thing I think, and as Drew knows, definitely, traveling with an ECMO is very intense, and the nurse is responsible for coordinating with RT, with APPs, with CT, or wherever the patient may be going. Usually you need about 1 or 2 additional nurses with you. And then we also bring an ECMO box, is what we call it. It just contains Epi-6, 10,000 units of heparin, albumin, and then I always like to bring another epi-drip if the patient isn't on one, just so you could initiate that too if something were to happen to the patient. The APPs have to come with us every time we're traveling off the unit, just because these patients are unstable. And then, of course, perfusion too. For code blue, as you guys probably know, VV, you would treat it as any other patient. And then VA, if they're in a lethal rhythm, but their flows are consistent, we would defibrillate them per ACLS. And then if they were to lose flows, that would be just initiating ACLS as usual. And then for LVADs, these are going to be our advanced heart failure patients. They're used as an advanced surgical option for patients that are not a candidate for open heart transplant, or they can be used as a bridge for patients waiting for a heart but need immediate intervention. Just like any other device, we're watching what's going on with these patients. We're watching the numbers on the actual LVAD controller, which is going to be that pump rate, your flow, your pulse index, and the pump power, and that's going to be on an hourly basis. For a blood pressure perspective, we're getting return to flows on them about every 4 hours, but again, it kind of depends on how the patient is presenting, and if they're warranting further assessment and more like consistent, we might get the flows, return to flow every hour or every 30 minutes. It just kind of depends. I think one thing that's important for the nurses too on this is patient or assessment is just super key for these patients, just because a lot of times their rhythm is thrown off just because they have that machine inside of their body. So it throws off their EKG rhythm, it throws off their pulse ox, and most of the time we're not even able to get a blood pressure cuff like on them because they have no native heart function. Some of the patients with a higher pulse index, actually we can get cuff pressures on them, but ideally if the patient is super sick, then we'll want an A-line in there just as more of an accurate representation. So usually these patients are pretty mobile. It just depends on how they're presenting. And then depending on how long, like since they've gotten their device, like post-operative, they will have sternal precautions. So just something to talk about. And then from a short to shield, I have listed too just the LVAD equipment that we're responsible for maintaining and having for the patient. So they'll have 4 batteries, and then they'll have their go bag, and then which just contains a backup controller and 2 more batteries, so 6 batteries in total, and then a mobile power unit too. So a short to shield is pretty rare, but it does happen. It's pretty much just an electrical fault in the drive line, so it can be perforation of the wiring, it can be the metallic shield that surrounds the wire is deteriorated, or damage to the insulation. So that can cause the pump to be unstable, of course. Usually we'll get LVAD alarms, and that'll show like intermittent drops on their flows or something like that. For these patients, we're only using batteries, and we're not actually connecting them to the mobile power unit. I don't exactly know like the mechanics behind it, to be honest with you. Like the electrical conduction, that's above my pay grade, but it's just important that usually we try to keep them on batteries versus the mobile power unit. So also changing like an LVAD exchange, like the controller exchange, can be beneficial to the patient and reduce like an adverse event happening. So again, pretty I've talked about it before, but most common among all the devices, of course, bleeding, hemolysis, thrombocytopenia, infection, limb ischemia, and then device malfunctions. So I think it's important, and I think we have a really good rapport between the nurses and the APPs and any part of the interdisciplinary team, but that we're just like notifying the provider, and as the nursing staff, we're being alert and constantly assessing these patients and their devices. And then just to kind of take away, I think attentiveness to the patient and the device is key when handling the situations, kind of what I've talked about. Nurses are usually the first to notice sudden changes, I feel like, to the patient, just because we're at bedside with them throughout the entire day, and especially depending on how involved the patient is. I think the APPs are great about coming into the room, talking with the patient, but again, they have a lot of patients to cover and other things to do, and that's our job as the nurse to be at bedside. So, but again, I think everybody takes part in this, but and then some patients have multiple devices. So you might have a patient that's on ECMO, but they still have a balloon pump, or they have an Impella, and then they're vented, and then they're on 8 drips, and then all this stuff. So there's a lot of devices that go into it. Not only are you assessing the patient, but you're also having to keep up with these devices, right? So I just think it's important, and I think our nursing staff is well trained. I think they prepare us well for it. And again, as the educator or one of the educators, it's our job to reinforce. And then communication, I think, is so key in all aspects of care, especially among the team. Building rapport with not only the patient and the family, but with the providers and all team members, I think, is super important. So that's all I got, but thank you guys for letting me present.
Thank you, guys. I know we're coming close to time, so I will open up the floor for questions. I do think we have one question in the chat that I would like to get to. What solution do you flush lines if a patient is allergic to heparin?
Can you guys still hear me?
Yes, we can still hear you, Jack.
That's honestly a great question. Drew might be able to answer that better. So from if it's heparinized saline, like if they're hit positive, I want to say like we just use normal saline and just further like anticoagulate the patient, possibly, but I don't have.
Jackson. Yeah.
I'm sorry.
What was that, Chelsea? I'm sorry.
Sorry, I didn't mean to interrupt, Jackson, but that's what I've seen is just using plain saline. And if they require further anticoagulation, like systemic anticoagulation, then a direct thrombin inhibitor.
Right.
Awesome. Okay. I want to again thank our speakers for their time. I do not see any other questions in the chat. So I want to also thank our attendees for joining and sticking with us, and look out for our next bite-sized lecture coming in October. Thank you very much, everyone. Have a good day.
Thank you.